Can you all see me? Can we begin? So this is a session on mixed bag must know MCQs on biochemistry. Can you all see me? Can we begin? So I have included 10 MCQs based on the prediction for what might come as MCQs in the upcoming NEET PG 2021. And I've also included mostly those MCQs or those topics which have not been discussed so far in the special classes. Okay. And before we start the session, a bit about Unacademy plans. Plus subscription gives you an access to both live and recorded sessions, and you also get an access to question bank with 25,000 plus questions. And Iconic subscription gives you an access to not only Unacademy platform but also to PrepLadder platform. And these are the special class features. You get an access to interactive live sessions, and you will be able to participate in polls. And this is about the updated question bank. And these are our star learners. And this is about the well-structured batch, which we have planned for both FMGE and next exam. The first one is Focus FMGE, the other one is Target Next. And both are structured courses, and these are aimed at making your preparation easy and solid. And these are the options that are available in the NEET PG 1 month package. And this is about the Grand Test series. And there is an offer that is going on which will help you in boosting your medical PG preparation. And let's now start discussing these MCQs. And this is an MCQ which was shared to me through my Telegram group. And the question is about Wilson's disease. In Wilson's disease, which of the following is decreased in urine? Tyrosine, phosphorus, serine, 3-methylhistidine. If not this MCQ, there is a higher probability that you get any MCQ on Wilson's disease, and that's why I thought we should discuss about this disorder. So can you try answering this? Let me see in the chat box if any one of you will be able to answer it. In Wilson's disease, which of the following is decreased in urine? And I hope you all know that. Yeah, very good, Divya. So Divya has answered it as 3-methylhistidine. So to answer this question, there is one fact which I want you all to know. I want you to know that Wilson's disease will present as aminoaciduria. So first, what is that you need to know about Wilson's disease? So Wilson's disease is a defect of, it's a defect of ATP7B. And what is the role of ATP7B? First, let me tell you about how copper gets absorbed along the intestine. You know, copper gets absorbed along the intestine, along the apical side through copper membrane transporter. Copper membrane transporter 1. It gets into the cell. And from the cell, for it to get across the basolateral side to reach the portal circulation, it is dependent on ATP7A. And only when a defect of ATP7A is observed, we call it as Menkes disease. So let's assume that it's normal in this person. So copper is entered into portal vein. And through portal vein, you know it reaches the hepatic sinusoids. From hepatic sinusoids, it gets into hepatocytes. And after copper gets into hepatocyte, it should be incorporated into apoceruloplasmin and should be converted to ceruloplasmin. And only in the form of ceruloplasmin, it can be released back into circulation. And that is done by ATP7B. So what is the function of ATP7B, which is basically a transporter? It helps in incorporating copper into apoceruloplasmin, converting it into ceruloplasmin, then it is released into circulation. And another function of ATP7B is that it is responsible for secreting copper into biliary ductules, because this is one way of you excreting copper. Copper is like having copper in your body is like a double-edged sword. On one hand, you need copper for various enzymes, right? What are the enzymes which are dependent on copper? This might be asked to you. So you will have to know the copper-dependent enzymes. One is, as you all know, it is a ceruloplasmin, number 1. Number 2 is the complex 4 of electron transport chain, which is cytochrome AA3. Superoxide dismutase 1 and 3. Both superoxide dismutase 1 and 3 need copper. They need copper and zinc. Okay, so it's needed for superoxide dismutase 1 and 3. And then lysyl oxidase. Yeah, lysyl oxidase, an enzyme which is involved in collagen cross-linkage formation. That needs copper. And tyrosinase. Yeah, tyrosinase and dopamine beta hydroxylase. Tyrosinase, dopamine beta hydroxylase. So this is the list that you need to remember as far as the question copper dependent enzymes are concerned. First, you should begin with ceruloplasmin, then it is cytochrome AA3, which is complex 4 of electron transport chain, superoxide dismutase 1 and 3, both of which are both copper and zinc dependent, lysyl oxidase involved in collagen cross linkages, tyrosinase and dopamine beta hydroxylase. Okay. So you need copper for these reasons. And on the other hand, copper also stimulates Penton's reaction. It causes oxidative stress. So there should be a balance in the level of copper in your body. So how do you get rid of excess copper? Copper gets excreted. It gets excreted into biliary ductule and it comes out of the body in the feces. So ATP7B has got two functions. One is incorporating copper into apoceruloplasmin, converting it into ceruloplasmin. Next is allowing copper to get excreted into biliary ductules. Okay. Now, what if it is secreted as ceruloplasmin into circulation? That way, ceruloplasmin is stabilized. Yeah, that way ceruloplasmin is stabilized. And then the ceruloplasmin allows copper to get incorporated into all those enzymes which need copper. Okay. Now, what happens when ATP7B is defective? When ATP7B is defective, copper separately gets into circulation, apoceruloplasmin separately gets into circulation. And that form of apoceruloplasmin is not stable. Yeah, it is unstable. So its half-life is reduced. So ceruloplasmin level will be reduced in Wilson's disease. So I want you to understand that in Wilson's disease, ceruloplasmin level being low is not the cause. It is the effect of Wilson's disease, because in this case, apoceruloplasmin is the form that is secreted into circulation, which is unstable, and its half-life is reduced. Okay, and the other effect is copper is in the free form in circulation, so it gets deposited in many places. Yeah, first it gets deposited in lenticular nucleus. That is why the name hepatolenticular degeneration. So why do we call it as hepatolenticular degeneration? Because the excess free copper gets deposited in lenticular nucleus, which would include globus pallidum and putamen. So when excess copper gets deposited in this region, that is the reason for lack of coordination and tremors and for neuropsychiatric manifestations. And when excess free copper gets deposited in the cornea, that is the reason for Kayser-Fleischer ring. In Descemet's membrane of cornea, Kayser-Fleischer ring is observed because of deposition of copper. Okay, and excess copper, because it's not able to get into biliary ductule, excess copper accumulates in liver. That causes oxidative stress of the liver. And oxidative stress of the liver is the reason for jaundice, hepatomegaly, liver cirrhosis, and even hepatocellular carcinoma. That is why it's hepatolenticular degeneration. And excess copper, excess free copper also damages proximal convoluted tubule. So it presents exactly like Fanconi syndrome. So when I say Fanconi syndrome, what do I mean? I mean to say PCT fails to reabsorb all solutes. So what you observe here is glycosuria, amino aciduria, phosphaturia. So do you remember here? One of the choices here is phosphorus. So I want you to know Wilson's disease presents like Fanconi syndrome. So phosphate level in the urine is increased and many other amino acid level in the urine will be high, including serine and tyrosine. Okay, so there are many studies which are done for amino acid profiling in Wilson's disease, and they have shown that the maximum rise in amino acid level in urine is observed for, it is observed for cysteine and threonine. When many amino acids get excreted in excess in urine, what are the two amino acids levels of which are very high in Wilson's disease? It is cysteine and threonine. Okay, and they found out that for unknown reasons, taurine level and 3-methylhistidine. 3-methylhistidine is a post-translational modification of histidine. So there is a decrease in taurine level and 3-methylhistidine in Wilson's disease. Okay, so what is the answer for this question? In Wilson's disease, which of the following is decreased in urine? Your answer should be 3-methylhistidine. Otherwise, I want you to know that Wilson's disease is a form of Fanconi syndrome. So glucose, phosphate, bicarbonate, amino acid, all these levels will be elevated in urine. Okay, and what are the other questions that might be asked to you? They might ask you which defect. Yeah, they might ask you which defect causes Wilson's disease. As I told you, ATP7B mutation causes Wilson's disease. That you have to know. And then apart from this, they might ask you what are the diagnostic criteria? How do you make a diagnosis of Wilson's disease? As I told you, decrease in ceruloplasmin level is one of the effects of Wilson's disease. So you can expect serum ceruloplasmin level. Yeah, serum ceruloplasmin level less than 0.2 grams per liter, less than 0.2 gram per liter is indicative of Wilson's disease. But the disadvantage of using ceruloplasmin level in finding out Wilson's disease is that ceruloplasmin is an acute phase reactant. So anybody who presents with liver disorder will have an acute inflammation. So ceruloplasmin level may be falsely elevated. So in Wilson's disease, when there is acute inflammation of liver, ceruloplasmin level might be falsely normal. Yeah, that is why you should not be making a diagnosis of Wilson's disease just based on ceruloplasmin level. And what do you think about serum copper? Do you think serum copper is high or low? Can any one of you type it? Serum copper level, will it be high or low? We know it's a copper excess disorder, right? Copper excess, copper is deposited in lenticular nucleus, it's deposited in cornea, deposition in liver, deposition in kidney. But what do you think about, very good, Sarah, you're right. So serum copper level is low. Yeah, reason is the copper level that is estimated is not just the free copper. We estimate free copper plus ceruloplasmin copper. And in Wilson's disease, because ceruloplasmin level is low, the total copper that is estimated is actually low. And because ceruloplasmin level is low, the free copper gets excreted in urine. So what is better? Instead of serum copper, what are you supposed to estimate? You're supposed to estimate urinary copper. Yeah, it's better to estimate urinary copper if it's more than 100 microgram in 24 hours. If urinary copper is more than 100 microgram in 24 hours, it is diagnostic. Yeah, it is diagnostic of Wilson's disease. If it is less than 40 microgram in 24 hours, you can exclude Wilson's disease. Are you clear? More than 100 microgram per 24 hours, almost diagnostic of Wilson's. Less than 40, you can exclude Wilson's. So between 40 and 100, it's not clear. The diagnosis will not be clear. And the best diagnostic criteria for Wilson disease is liver copper. Yeah, liver biopsy and then estimating copper level. Okay, so if liver copper is more than 250 microgram per gram of tissue, if liver copper is more than 250 microgram per gram of tissue, that is diagnostic. That's the gold standard for diagnosis of Wilson's disease. Okay, so all that you need to know is totally 6 or 7 facts. You need to know it's a mutation of ATP7B. You need to know the function of ATP7B. It incorporates copper into apoceruloplasmin, converting it into ceruloplasmin. It also helps in secreting copper into biliary canaliculi. Okay, so when that is defective, free copper and apoceruloplasmin get into circulation. Apoceruloplasmin is a destabilized form, so ceruloplasmin level is low. And free copper will get deposited in all tissues, causing oxidative stress. So oxidative stress of globus pallidum and putamen is the reason for lack of coordination. It is also the explanation for tremors and psychiatric manifestations. And excess deposition of copper in the cornea is the reason for KF ring or Kayser-Fleischer ring. And copper-mediated oxidative stress in the liver is the reason for hepatocellular carcinoma in extreme conditions, or it is the reason for liver cirrhosis, jaundice, and hepatomegaly. And renal damage presents as Fanconi syndrome. So answer to this question. Yeah, hepatic copper is high. So answer to this question is 3-methylhistidine. And what is the other one level of which is Low, I said taurin. Both these levels are low in Wilson's disease. Okay. So that's all about question number 1. So this is question number 2. Crossing over true is. So many a times we think we are well aware of what is crossing over. We are well aware of translocation, but minute details we might not know. And this has been asked repeatedly. That is why I've included this in the discussion. So try to answer this. Crossing over true is. Does it occur during diplotin stage? Does this ring a bell? You must have learnt about this in your first year, right? First year or in your school. Yeah, leptotin, zygotine, pachytene, diplotin, diakinesis stages. All these happen in prophase 1 of meiosis 1. So does it happen in diplotin stage? Is it between non-sister chromatids of homologous chromosomes? Or is it between sister chromatids of homologous chromosomes? Is it between non-homologous chromosome sister chromatids? What do you think is the right answer? Can I expect an answer in the chat, live chat? Zinc interferes with copper absorption. Can I expect an answer for this? Does it occur during diplotin stage? Okay, let me help you answer this question because I haven't gotten the answer yet. I want you to know that crossing over happens. Okay, somebody says it's C. David, good David, you think it's between sister chromatids of homologous chromosomes. Manish thinks it's between non-homologous chromosomes, sister chromatids. Any other answer? There are only 2 more choices left out. You can give it a try. So I want you to know that crossing over happens in pachytene stage. Yeah, it happens in pachytene stage of prophase 1 of meiosis 1. And it is between non-sister chromatids of homologous chromosomes. You all understand this? It's between non-sister chromatids of homologous chromosomes. So I will explain you this. So first about mitosis, then I'll tell you about meiosis. I'm not going to get in the details. I won't be wasting your time much. I'll tell you only those details that you need to know to understand what is isochromosome. I'll tell you only those details which you need to understand what is crossing over, what is translocation, what is Robertsonian translocation, and why is it the most common cause of repetitive Down syndrome in young mothers. So closely follow this discussion for 10 minutes. You'll be able to understand many concepts. Okay. So first about mitosis. Mitosis happens in somatic cells. And as a result of mitosis, one diploid cell would give rise to 2 diploid cells. Yeah, one cell with 2 sets of chromosome will give rise to 2 cells with 2 sets of chromosome. So that's what you need to know about mitosis. And this mitosis happens in M phase of cell cycle. We know cell cycle goes through G0, G1, S, G2, M phase. Right? So mitosis happens in which phase? M phase of cell cycle. So prior to M phase, we call these phases as interphase. Yeah, we call these phases as interphase because it is interplaced between a complete resting phase. G0 is a resting phase. So we call this as interphase because it is interplaced between complete resting phase and active cell division phase. Okay. And what happens in interphase? So I'm going to show you mitosis of a hypothetical cell with just one pair of chromosome. Yeah, it is mitosis of a hypothetical cell with just one pair of chromosome. One is a paternal chromosome and the other one is a maternal chromosome. I've shown maternal chromosome in red color, paternal chromosome in purple color. Okay, so this cell first gets into interphase. And what happens in interphase? Please remember, in interphase there will be uncondensation of chromosome. Yeah, there will be uncondensation of chromosome. Those of you who have attended my special classes will know why. So interphase, what happens? The first thing that happens is uncondensation of chromosome. Okay, so Both the chromosomes have now undergone uncondensation. And the second thing that happens in interphase, particularly in S phase, is replication. And following replication, there will be duplication of both these chromosomes. So now you have two long threads held close to each other, representing two daughter DNAs. Okay. So what are the two events that happen in interphase? In interphase, there is uncondensation of chromosome and there is duplication of chromosomes. Now such a cell gets into prophase. Yeah, it is getting into mitosis. In mitosis, the first phase is prophase. So what happens in prophase? Please memorize this. Prophase is always for two events to happen. The first event is condensation of chromosome, because in both resting phase and in mitotic phase, you want condensed chromosome. Yeah, in both resting phase and in mitosis, you want condensed chromosome, whereas in interphase, it is uncondensed. So once interphase is over, once it is just getting into mitosis, the first thing that should happen is condensation of chromosomes. So following condensation of chromosome, a chromosome would start looking like a letter X. Why does it look like a letter X? Because now it has got two copies of short arms and two copies of long arms. Okay, so this is prophase. The first event of prophase is condensation of chromosome. And the second event of prophase is pairing of homologous chromosomes. What do you mean by homologous chromosomes? We know we have two copies of every chromosome. Chromosome 1, we have two copies. Chromosome 2, we have two copies. Chromosome 3, you have two copies. So those two copies of every chromosome will be called as homologous chromosomes. So after condensation of chromosome, there is pairing of homologous chromosome. Chromosome 1 comes close to 1, 2 comes close to 2, 3 comes close to 3. Okay, so these are the two events that happen in any prophase. It can be prophase of mitosis or it can be prophase 1 of meiosis 1. That's immaterial. These two events always happen in prophase. Okay. Now after this, it is getting into metaphase. And what happens in metaphase? In metaphase, mitotic spindle is formed. Okay, in metaphase, mitotic spindle is formed. Let me use green color for mitotic spindle. So mitotic spindle is formed and it gets attached to centromere. Okay, it gets attached to centromere. And in anaphase, so this is what is happening in metaphase. Mitotic spindle is formed, it gets attached to centromere. And what happens in anaphase? In anaphase, when the mitotic spindle contracts, the centromere breaks longitudinally. Yeah, the centromere breaks longitudinally, and one long arm and one short arm goes to one pole. Yeah, one long arm and one short arm goes to one pole. The other long arm and the other short arm goes to the other pole. So in telophase, when the nuclear membrane reappears, when the nuclear membrane reappears, from one diploid cell with one pair of chromosomes, you have formed two diploid cells, each with one pair of chromosome. So this is all that is expected out of you to know as far as mitosis is concerned. Okay, so what are the facts that you have learned about mitosis? The first fact is it happens in somatic cell, and as a result of mitosis, one diploid cell gives rise to two diploid cells, and mitosis happens in M phase of cell cycle, and prior to M phase there is an interphase. In interphase there is uncondensation of chromosome and duplication of chromosome. Please memorize it. In S phase or synthetic phase, you synthesize two double-stranded DNA from one double-stranded DNA, or in other words, in S phase, replication happens. Okay, so after uncondensation, after duplication, these chromosomes get into mitosis. In mitosis, the first phase is prophase. What are the two events that happen in any prophase? Can you type it? What happens in? What are the two events that happen in any prophase? I'm expecting you to answer. Yeah, what are the two events that happen in prophase? Condensation of chromosomes, very good. Condensation of chromosome and pairing of homologous chromosomes. So after condensation and after pairing of homologous chromosomes, prophase is over, it gets into metaphase. In metaphase, mitotic spindle is formed. Very good. Mitotic spindle is formed, it gets attached to centromere. And in anaphase, when the mitotic spindle contracts, centromere breaks longitudinally. One long arm and one short arm goes to one pole, the other long arm and the other short arm goes to the other pole. And in telophase, nuclear membrane reappears. So as a result of mitosis, you have got two diploid cells. Now, what is isochromosome? When do you think isochromosome is the result? In anaphase, when the mitotic spindle contracts, if the centromere instead of breaking longitudinally, breaks transversely. Yeah, during anaphase, when the mitotic spindle contracts, the centromere, if instead of breaking longitudinally, breaks transversely. And if two long arms and two short arms, if two long arms go to one pole and two short arms go to the other pole, that is called as isochromosome. So it's a defect of anaphase. Is it clear? Okay. So that's all about mitosis. Now let's learn about meiosis. This is where I'm going to tell you about crossing over. I'll also tell you the significance of it. Okay. So meiosis happens if mitosis happens in somatic cell, meiosis should happen in germ cells. And as a result of meiosis, one diploid cell will give rise to 4 haploid gametes. Yeah, one diploid cell gives rise to 4 haploid gametes. And meiosis happens in 2 stages, meiosis 1 and meiosis 2. And both meiosis 1 and 2 happen one after another in M phase of cell cycle. Yeah, they also happen in M phase of cell cycle. So prior to meiosis, there is again interphase. So what do you think happens in interphase? So if this is the germ cell to begin with, these chromosomes will undergo uncondensation, right? They undergo uncondensation. And after uncondensation, what happens in interphase again? There is duplication of all these chromosomes. Okay, so this is happening in interphase. And after interphase, it is getting into meiosis 1. Meiosis 1 has got prophase 1. So in prophase 1, what did I tell you always happens? Prophase 1 of meiosis 1, what happens again? Condensation of chromosome. So let me show you again maternal chromosome as red color. So after condensation, this is how the chromosome would look like a letter X. And the second event that happens in prophase 1 is pairing of homologous chromosomes. Yeah, pairing of homologous chromosomes. Now, after this, something unique happens in prophase 1. Yeah, something unique happens in prophase 1. Before I tell you what happens, I'll tell you what are sister chromatids and what are non-sister chromatids. The two short arms, yeah, the two short arms or the two long arms which are attached to the same centromere, which are copies of each other. Yeah, the two short arms or the two long arms which are attached to the same centromere, which are copies of each other, will be called as sister chromatids. So what are non-sister chromatids? Chromatids which are attached to different centromere. Yeah, chromatids which are attached to different centromere will be called as non-sister chromatids. Okay. So after pairing of homologous chromosomes, what happens is there is breakage and exchange of genetic material. There is breakage and exchange of genetic material between non-sister chromatids of homologous chromosomes. And this is called as crossing over. And this crossing over happens in patchy teen stage. Please memorize this. It happens in patchy teen stage of prophase 1 of meiosis 1. And as a result of this crossing over, you see that paternal segments are getting mixed with maternal segments and vice versa. Yeah, paternal segments are getting mixed with maternal segments and vice versa. And this is when there is a possibility of new trait appearing. Yeah, and this is the basic tool of evolution. You know, you're not an exact replica of your mother or of your father. You know, you have your own unique features, a unique combination of sequences. And what gives rise to that unique combination of sequences? It is crossing over, which is breakage and exchange of genetic material between non-sister chromatids of homologous chromosomes. It happens in patchy teen stage of prophase 1 of meiosis 1. Okay, with this, what is over? Prophase 1 is over. Now it is into metaphase. As always, what happens? Yeah, hi Swati. So as always, what happens in metaphase? Even in metaphase 1, mitotic spindle is formed. It gets attached to centromere. And in anaphase 1, yeah, normally in anaphase, I told you when the mitotic spindle contracts, centromere breaks longitudinally. That happens in mitosis. Whereas in meiosis 1, in anaphase 1, when the mitotic spindle contracts, centromere does not break, and as a whole, paternal chromosome goes to one pole, maternal chromosome goes to the other pole. So in telophase, when nuclear membrane reappears, yeah, in telophase, when nuclear membrane reappears, this is how it would look. Both now have only one copy of both. Sorry. Both will now have only one copy of a pair of homologous chromosomes. So to start with, they are diploid. But as a result of meiosis 1, yeah, as a result of meiosis 1, you have formed two haploid cells because now they have only one chromosome each. Okay, so it's a reduction division. Okay, it's one chromosome each, so it is a reduction division. It's a haploid gamete that is formed as a result of meiosis 1. Now, both these haploid gametes get into meiosis 2. There is no interface between meiosis 1 and meiosis 2. They straight away get into meiosis 2. Meiosis 2 has got prophase 2, metaphase 2, anaphase 2, and telophase 2. Nothing significantly happens in prophase 2. Why? Usually, prophase is for condensation of chromosome. Here, the chromosome is already condensed, right? And it's for pairing of homologous chromosomes. Do you find any homologous chromosome that can be paired here? No. So nothing happens in prophase 2, and both these straight away get into metaphase 2. What happens in metaphase 2? Mitotic spindle is formed. It gets attached to centromere. Yeah, and in anaphase 2, when the mitotic spindle contracts, the centromere breaks longitudinally. Okay, so one long arm and one short arm goes to one pole. The other long arm and the other short arm goes to the other pole. So how many cells have you formed? Yeah, how many cells have you formed? You have formed 4 haploid gametes. Okay, so that is all about meiosis. Is it clear to everybody? Yeah. So as a result of meiosis, one diploid cell has finally given rise to 4 haploid gametes. Okay. So yes, there is an arrest before meiosis 2. Yes. Okay. So we get 4 haploid gametes. So this is all about meiosis. Okay. So are you clear about this question now? Crossing over truest. Does it occur during, please tell me true or false, does it occur during diplotein stage? Yeah, does it occur during diplotein stage? No, it happens during patchy teen stage. Is it between non-sister chromatids of homologous chromosomes? Just remember the picture. Yeah, these are sister chromatids. When it is attached to a different centromere, they are non-sister chromatids. So it is between non-sister chromatids of homologous chromosomes. Okay, it's between non-sister chromatids of homologous chromosomes. If it's between sister chromatids, that also happens sometimes. That's called a sister chromatid exchange. Yeah, that is not crossing over. What do you call it? A sister chromatid exchange. Now, what is translocation? What is translocation? What is crossing over? You said crossing over is between non-sister chromatids of homologous chromosomes. So what is translocation? Translocation is between non-sister chromatids of non-homologous chromosomes. Instead of chromosome 1 getting paired with 1, 2 getting paired with 2. If chromosome 14 gets paired with chromosome 21, and if there is breakage and exchange that happens between them, then that's called as translocation. Are you clear? So crossing over is between non-sister chromatids of homologous chromosomes. Translocation is between non-sister chromatids of non-homologous chromosomes. Okay. So answer for this question is choice B, between non-sister chromatids of homologous chromosomes. So answer this question, transfer of genetic material in one meiotic division between two non-homologous chromosomes. It's a must-know MCQ because it's a PGI question. Yeah, transfer of genetic material in one meiotic division between two non-homologous chromosomes. What is the answer? It is translocation. So now I have a question to you. Why are you happy when it's between homologous chromosomes? Why are you unhappy when it's between non-homologous chromosomes? You say if it's between homologous chromosomes, it's just a crossing over and you're very happy that it results in evolution. But if it's between non-homologous chromosomes, you call it as a translocation and you know that results in a disorder. So why are you worried about it? Because if it's homologous chromosome, say chromosome 1 with chromosome 1, yeah, if it's homologous chromosome, it means the gene sequence would be the same. Yeah, if chromosome 1 has got albumin gene close to centromere, and then there is a beta globin gene after that, and then there is a ceruloplasmin gene. Yeah, there is no chromosome with this gene sequence. I'm just giving you as an example. Yeah, suppose there is a chromosome with A, B, C gene sequence, which has got paired with the homologous chromosome. Then this homologous chromosome, the gene sequence will be the same. It will also have albumin, beta globin and ceruloplasmin gene, but the allele will be different. If one chromosome, if the paternal chromosome has got capital A, capital B, capital C allele, maternal chromosome might have small a, small b and small c allele. That's all the differences. So when there is breakage and exchange between these homologous chromosomes, yeah, when there is breakage and exchange between homologous chromosomes, maximally what happens is capital B allele is paired with small c and small b is paired with capital C. Yeah, this is not going to cause any detrimental effect. It is going to happen normally. The person is going to be perfectly normal. Whereas instead of one getting paired with one, if it gets paired with two, the gene sequence in two is going to be totally different. Yeah, two will have XYZ gene sequence. Yeah, chromosome 2 will have XYZ gene sequence. And in that case, if there is breakage and exchange, what happens is capital B gene is paired with capital Z. Yeah, capital B gene is paired with capital Z and Y is paired with capital B. In which case, the B gene product might interfere with Z expression or the Z gene product might interfere with B expression. Do you understand this? In this case, B gene product might interfere with Z expression. Z gene product might interfere with B expression. Or sometimes B gene sequences and Z gene sequences together form one transcription unit. They form one gene and they produce a fusion product. Yeah, that produces a fusion product which has totally different properties. Do you know an example for it? A fusion product with totally different property resulting in a disease. 15-17 translocation. Yeah, acute myeloid leukemia of M3 type, acute promyelocytic leukemia. Yeah, what happens here? Here the chromosome 15 has got promyelocytic leukemia fragment. 17 has got RAR alpha fragment. Very good. Yeah, promyelocytic leukemia fragment is present in chromosome 15 and RAR alpha fragment is present in chromosome 17. So when there is a balanced translocation between these two chromosomes, the PML fragment comes close to RAR alpha fragment. And together they form one gene and they produce a fusion product of retinoic acid receptor. They form a fusion product of retinoic acid A receptor alpha. Usually, you know, retinoic acid A receptor and RXR together help in growth and differentiation of cells. So this fusion product does not have that effect. So there is a differentiation arrest. So promyelocytes are not able to get converted to myelocytes. Okay, so that is why it results in promyelocytic leukemia. And this can be treated by giving all trans retinoic acid, which supports more function of retinoic acid receptor alpha, and that supports differentiation of promyelocytes into myelocytes. Do you all understand this? So this is why you're worried about translocation and you're happy when it's between homologous chromosomes. Okay. So between non-homologous chromosomes, it can result in a disease because that can be difference in the level of gene expression, or it can produce a new protein with varying functions. So transfer of genetic material in one meiotic division between two non-homologous chromosomes is called as translocation. So the most common cause of repetitive Down syndrome in young mothers is Hi Aditya. Can you answer this? I even gave you the answer a few minutes back. The most common cause is what? Can anybody tell me the answer? No one? The most common cause of repetitive Down syndrome in young mothers is Robertsonian translocation involving chromosome 14 and 21. Yeah, involving chromosome 14 and 21. Now we know what is translocation. It is between non-sister chromatids of non-homologous chromosomes. And what is Robertsonian translocation? Robertsonian translocation is given a special name when there is breakage and exchange of genetic material between acrocentric chromosomes. Yeah, what are acrocentric chromosomes? What are metacentric chromosomes? All this classification is based on the location of the centromere. If the centromere is in the center and if both the arms are almost of the same size, yeah, you call them as metacentric chromosomes. And in this case, ratio of long arm is to short arm length. Yeah, ratio of long arm to short arm length will be between 1 to 1.7. Between 1 to 1.7. And what are acrocentric chromosomes? In acrocentric chromosomes, the centromere is pushed far towards one side. So one arm is too short and the other arm is too long. Okay, and in this case, ratio of long arm to short arm is more than 17. Yeah, if it's more than 17, then that's called as acrocentric chromosomes. An example for acrocentric chromosomes will be chromosome Y, 13, 14, 15, chromosome 20 and 21. Yeah, so there are 6 examples for acrocentric chromosomes: chromosome Y, 13, 14, 15, 20 and 21. And the classical feature of these acrocentric chromosomes is that the short arms do not have any coding sequences. Yeah, they have only just repetitive sequences here. They do not have any coding sequences. Only then you will call it as acrocentric chromosomes. So when two such acrocentric chromosomes get paired, yeah, when chromosome 14 gets paired with chromosome 21, when there is breakage and exchange, it happens along the centromere. These two short arms are too short for breakage and exchange to happen. So breakage and exchange happens along the centromere, and the two short arms get paired to form a very small chromosome, and the two long arms get paired to form a long chromosome. Yeah, so this is 1421 translocated chromosome. And these two short arms chromosome gets lost in due course. Because there is a telomeric end shortening which happens progressively, this chromosome gets lost in this person, but the person will be absolutely normal because they don't have any coding sequences. But what is the defect in this person? In this person, they have only one chromosome representing sequences of chromosome 14 and sequences of chromosome 21. Okay, so what happens when this person starts producing gametes? When this person starts producing gametes, as always, you know, in interphase, there is going to be duplication of these chromosomes. Yeah. So after duplication, it gets into metaphase 1. In metaphase 1, mitotic spindle is formed and gets attached to centromere. When the mitotic spindle contracts, this as a whole goes to one pole. Yeah, the other pole does not have any sequences that are representative of chromosome 14 and 21. Okay, so this gamete is not viable, it dies. So this person always produces one type of gamete which has got two copies of chromosome 14 fragments and two copies of chromosome 21. Okay, this gets into meiosis 2. When it gets into meiosis 2, again what happens? Prophase 2, metaphase 2, mitotic spindle gets attached to centromere. And in anaphase 2, when the mitotic spindle contracts, the centromere fails to break because it's an abnormal centromere that is formed. Here the centromere fails to break. Okay, so as a whole, this goes to one pole. Again, they produce only one type of gamete, and this gamete is going to have a chromosome which has got two copies of segments of chromosome 14 and 21. Now, when this is getting fertilized by a normal gamete, that normal gamete provides with normal chromosome 21. So the resultant zygote will have three copies of all genes of chromosome 21, and that causes trisomy 21 or Down syndrome. And usually Down syndrome is observed in elderly mothers, but this is going to be observed in a young mother because this is how the person produces gametes always, and it's going to be a repetitive Down syndrome. Okay, so what is the most common cause of repetitive Down syndrome of young mothers? Is this compulsory to remember all the examples of chromosomes? Um, you have no other go but to memorize many facts as far as NEET exam or FMG or any entrance exam is concerned, because you do not know what fact will be asked where. And I would like to tell this to every aspirant of any entrance examination. For you to be able to write any exam, there is a way or there is a sequence in which you have to learn. Yeah. So the first step is learning and memorizing all facts. And after you learn and memorize all facts, you will start understanding concepts. And then you will be able to apply it. Yeah, if you follow the sequence, you will start cherishing any subject which you learn. Okay, and only because we don't follow the sequence, many a times we don't cherish the application aspect of a subject, because either we think, I don't want to memorize these facts, I'm going to be a doctor, I should know only to apply it. Yeah, if you don't follow the sequence, that's not going to happen. So you will have to memorize facts, then you have to understand concepts. And many times what we do is we memorize all facts and then we start applying. We don't understand concepts. So for you to be able to shine as a doctor in any field, yeah, if you follow the sequence, the field which you choose does not matter. Yeah, I would say the field you choose does not matter. All that matters is your interest for that field. Yeah, so I would not say that anybody or everybody should take only the so-called top PG courses to be successful in life. Yeah, I'm not naming any subject. Yeah, because it's subjective, right? So I'm not going to name any subject. You might have a perception that this is the subject which is going to bring me success in life, but all those are just perceptions. Yeah, if you are very clear about concepts, the field which you get into does not matter. You will be able to shine in the field. So I always say this, you cherish this period when you're preparing for an entrance examination, because it's a golden period that is given to you for you to assimilate all that you have learned all these years. Okay, so don't get bugged or don't get frightened about the humongous task that is kept in front of you. Yeah, I mean, if you start enjoying it, it's not humongous. You will understand that it's something just interesting. It's as sweet as how you would feel when you do something which you like. Okay, so always memorize. Try to memorize as many facts as possible. Try to understand as many concepts as possible, and then try applying it. You will like medicine. Okay. Okay. So thanks for asking that question, Doda Teja. That I wanted to say this for a very long time. So I've told you now. Okay, so what is the most common cause of repetitive Down syndrome in young mothers? The most common cause of repetitive Down syndrome in young mothers is Robertsonian translocation involving chromosome 14 and 21. And what are the facts that might be asked to you? What are the acrocentric chromosomes? You will have to know it is Y chromosome 13, 14, 15, 20, and 21. Okay. Okay. This is an interesting question. This was asked in AIMS, I think 3 years back. And this was not asked in such a detailed manner. Yeah, the question was NARP is an example of. Yeah, the question was NARP is an example of. Okay, so I didn't want you to get confused with that single term. That is why I've given you a detailed explanation in the question. So a family was reported with many cases of mental retardation, developmental delay. Some presented with retinitis pigmentosa. 3 neonatal deaths with lactic acidosis in the family forced them to consult a geneticist. A pedigree chart was drawn. I have not attached it here. DNA was extracted from all affected members. PCR RFLP detected a point mutation at one specific site in the mitochondrial DNA. Yeah, this is a clue that is given to you. It's a mitochondrial DNA mutation. The explanation for variable presentation caused by a single mutation site is. In all these family members, there is one common mutation in mitochondrial DNA, but the presentation is variable, starting from somebody with just mild mental retardation, mild neuropathy, mild developmental delay, retinitis pigmentosa, or somebody who have died. 3 neonatal deaths with lactic acidosis, yeah, which is Leigh syndrome. Yeah, this is Leigh syndrome on one hand and NARP on the other hand. What does NARP stand for? Neuropathy, ataxia, retinitis pigmentosa. So this syndrome, yeah, with multiple presentation. It's not a syndrome. There are multiple forms of presentation of one disorder, which is caused by ATPase. Yeah, ATPase 6 subunit of mitochondrial DNA. So this one gene mutation can present with so many presentations. And what is the reason for this? Thank you, Bhuvana madam. Thank you. Yeah. Is it locus heterogeneity? Is it pleiotropy? Is it allelic heterogeneity? Is it heteroplasmy? Can anybody answer this? Okay, many of you have answered it as heteroplasmy. Good. Sayak Chakrabarti has answered it as pleiotropy. Let me tell you what is pleiotropy first. Pleiotropy is one mutation affecting multiple systems. Do you all understand this? Pleiotropy is very simple. One mutation, one gene mutation affecting multiple systems in a person. There are many disorders which present with pleiotropy, right? Even the Wilson's disease, which I discussed to begin with. Yeah, it's a mutation of one gene, but the effect is observed in renal tubules, it's observed in liver, it is observed in lenticular nucleus. So that is pleiotropy. Okay, so we have excluded that. It is not about different systems, it's about various presentation. Now, can it be locus heterogeneity or can it be allelic heterogeneity? What is allelic heterogeneity? Multiple sites mutation in one gene. Allelic heterogeneity means multiple sites mutation in one gene causing variable presentations. Yeah, depending upon whether it's a splice mutation or is it an insertion or is it a deletion or is it a point mutation, the effect is going to be variable. Yeah, so that is called as allelic heterogeneity. Here, the mutation happens in one gene. Okay. Now, what is locus heterogeneity? Locus heterogeneity is multiple gene mutation. Yeah, X, Y, Z. Multiple gene mutation causing the same disorder. Multiple gene mutation causing the same disorder or a similar presentation. For example, osteogenesis imperfecta. Yeah, osteogenesis imperfecta is caused by collagen, type 1 collagen, right? Osteogenesis imperfecta type 2 is caused by type 1 collagen defect. But type 1 collagen is a triple helix. And two of those polypeptide chains are represented in chromosome 17. One is represented in chromosome 15. So irrespective of whether there is a mutation chromosome 17 gene or in chromosome 15 gene, it is going to ultimately present in osteogenesis imperfecta 2. Yeah, that is called as locus heterogeneity. Is it clear so far? I want you to be very clear about all these genetics terms because when you read it, you think you have understood it. But when you try answering an MCQ, you will find it difficult. So you have to be very clear, and that clarity you will get only when you understand examples. Okay. So what is pleiotropy? I told you one mutation causing or affecting multiple systems is pleiotropy. What is locus heterogeneity? Multiple loci mutation causing a similar disorder. Example, osteogenesis imperfecta. Allelic heterogeneity is within a gene, multiple site mutations causing disorders with multiple presentation. Okay, that's called as allelic heterogeneity. Now, what is heteroplasmy? Heteroplasmy is a feature of only mitochondrial DNA mutations. Yeah, it is mitochondrial DNA mutation. Only in that case it presents as heteroplasmy. Now, what is the reason for this heteroplasmy? Till some time back, we were happily saying that mitochondrial DNA mutations are only maternally inherited. Didn't we say that? Yes or no? Yeah, it's a statement that is given even in Harper. Mitochondrial DNA is only maternally inherited. But later, I mean, why do we say so? Because we know during zygote formation, all that the sperm contributes with is its pronucleus, right? The remaining parts of the sperm will be shed down. So mitochondria is present only in the remaining part. So even if the sperm mitochondrial DNA is mutated, it is not going to get into the zygote. That is why we always say mitochondrial DNA mutations are only maternally inherited. But later we found out that even the middle piece of sperm, yeah, even the middle piece of sperm gets into zygote. And that middle piece of sperm can have up to 5 mitochondria. Yeah, middle piece of sperm can have up to 5 mitochondria, and within mitochondria there will be multiple copies of mitochondrial DNA. But then the effects are diluted in the zygote because ova contributes. Yeah, ova contribute around 2 lakh mitochondrial DNA. So in the zygote, if you see, there is 2 lakh mitochondrial DNA from ova and close to like 5 to 20 mitochondrial DNA from sperm. So if the sperm mitochondrial DNA is mutated, that effect is going to be diluted. And that is why most commonly these mutations, these mitochondrial DNA mutations look as if it's purely maternally inherited. But sometimes, depending upon the number of mitochondria which get into zygote, or depending upon the number of copies of mitochondrial DNA that are present within the mitochondria, the effects can vary. Okay, so if the paternal DNA, yeah, if the paternal DNA copy, number of paternal DNA copy that is present finally in the zygote is more, and if the mitochondrial DNA is mutated, yeah, if the mitochondrial DNA is mutated, the presentation will be milder. Do you all understand this? So truly or actually it is only maternally inherited, but depending upon the number of copies of mitochondrial DNA that we receive from sperm, the effects are going to vary. And if ultimately, if the number of mutations, if the number of DNA with mutation is between 60 to 65 percentage, then it presents with a milder form, which is just mild mental retardation, which is just mild mental retardation. Whereas if more than 90% of mitochondrial DNA in a person has got the mutation, that is going to present as Leigh syndrome. Yeah, that is going to present as Leigh syndrome, which presents with mitochondria getting affected too much. So it presents as lactic acidosis and neonatal death. Okay, and in between, depending upon the percentage that is observed, it can present with just neuropathy, or it can present with retinitis pigmentosa, or it can present as NARP. What is NARP? I said neuropathy, ataxia, retinitis pigmentosa. So this is called as heteroplasmy. So what is heteroplasmy? Varying presentation of mitochondrial DNA mutation. Yeah, varying presentation of mitochondrial DNA mutation that is observed because of the difference in the number of mitochondrial DNA inherited by the zygote from the sperm. Okay, so more than 90% mitochondrial DNA mutation, the presentation will be severe. Less than 60%, it will be mild. Okay, so this is all you need to know. So if you are shown as a mitochondrial DNA mutation with multiple presentation, your answer should be heteroplasmy. Okay, any doubt here? So I will finish the session with this because it's already almost 1 hour. Um, so hypertriglyceridemia is seen in all except. Can you answer this? I'll give you 1 minute or 30 seconds time to answer. What is the answer for hypertriglyceridemia seen in all except? I'm going to use this question to tell you about Fredrickson's classification of hyperlipoproteinemias. At least the basics I'll tell you. Okay. Is it similar to anticipation? What is similar to anticipation? Heteroplasmy is not similar to anticipation. Anticipation is a feature of trinucleotide repeat disorders. Is that clear, David? Anticipation is a feature of trinucleotide repeat disorders when you will have to anticipate the disorder at an earlier age over successive generations. For example, Huntington's chorea, the first generation patient presents in the 6th decade. The next generation patient would present in the late 5th decade. The third generation patient in the early 5th decade. So the age of presentation gets preponed over successive generations. That's called as anticipation. That's a feature of trinucleotide repeat disorders. What I told you now is heteroplasmy, which is a feature of mitochondrial DNA mutation. Very good. David has answered it right. Sarah has answered it right. So what is the answer here? Hypertriglyceridemia seen in all except. The answer is choice C. It is seen in all except type 2A hyperlipoproteinemia, because type 2A hyperlipoproteinemia is otherwise called as familial hypercholesterolemia. Yeah, it is otherwise called as familial hypercholesterolemia, and it is caused by a defect of LDL receptor, sometimes because of ApoB100 defect, but many a times it's because of LDL receptor defect. And if LDL receptor is defective, LDL will not be cleared off from circulation. LDL carries cholesterol. So in this case, there will be an isolated elevation of cholesterol, no elevation of triglyceride. Okay, so hypertriglyceridemia seen in all except. Your answer should be choice C, or type 2A hyperlipoproteinemias. Okay, now about von Gierke's, I've already told you it's a feature. One of the features of von Gierke's is hypertriglyceridemia, because von Gierke's is a defect of glucose 6-phosphatase. Yeah, it's a defect of glucose 6-phosphatase. So glucose 6-phosphate gets into glycolysis. It forms pyruvate. Pyruvate becomes acetyl-CoA. Acetyl-CoA will be used for fatty acid synthesis. Fatty acid has to be stored as triacylglycerol. So please remember, if not for this question, even if they ask you about von Gierke's disease, you should know that it presents as hypertriglyceridemia. Alcoholism is a form of anabolism. Yeah, high NADH NAD ratio. It's a form of high NADH NAD ratio. High energy, it's a form of anabolism. So this also presents with hypertriglyceridemia. Nephrotic syndrome, we lose all smaller proteins, yeah, through glomeruli. So there is a compensatory oversynthesis of larger proteins by liver. And one of the larger proteins that's released by liver is VLDL. So VLDL carries triglyceride. So one of the features of nephrotic syndrome is dyslipidemia. It presents as hypertriglyceridemia. So your answer should be type 2A hyperlipoproteinemia. I want you to know that it's called as familial hypercholesterolemia, caused by a defect of LDL receptor. Okay. Now quickly I will tell you just the classification of hyperlipoproteinemias. Hyperlipoproteinemias will be classified or can be classified as those which present with an isolated elevation of cholesterol, those which present as an isolated elevation of TGL, and those which present with both. I'm going to just tell you the names here. I'll probably explain you about this later for want of time. So isolated elevation of cholesterol is just type 2A. It is just type 2A caused by a defect of LDL receptor. Isolated elevation of triglyceride is type 1, type 4 and type 5. Yeah, isolated elevation of triglyceride is type 1, type 4 and type 5. Type 1 is otherwise called as familial chylomicronemia syndrome. Type 1 is otherwise called as familial chylomicronemia syndrome. Chylomicron carries TGL, so it's going to be an isolated elevation of TGL. Type 4 and type 5, they are called as familial hypertriglyceridemias. Yeah, they're called as familial hypertriglyceridemias. Now, what are the conditions which present with both? What is remaining? Type 2b is remaining and type 3. Type 2b and type 3 are mixed disorders. Type 2b is called as familial combined hyperlipidemia. Type 2b is called as familial combined hyperlipidemia. Okay, and type 3 is otherwise called as familial dysbeta lipoproteinemia. It is otherwise called as familial dysbeta lipoproteinemia. So if you know this classification, you will be able to answer many questions related to Fredrickson's classification of hyperlipoproteinemias. So what are the conditions which present as an isolated elevation of TGL? It is 1, 4 and 5. 1 is familial chylomicronemia syndrome. 4 and 5 are familial hypertriglyceridemias. Isolated elevation of cholesterol is type 2A, which is familial hypercholesterolemia. Both will be type 2B and type 3. Type 2B is familial combined hyperlipidemia. Type 3 is familial dysbeta lipoproteinemia. Okay. So that's about this question. So answer to this question is type 2A hyperlipoproteinemia. Okay. So thank you and all the best. Don't give up at any point of time. This is the time wherein you have to be on your toes, and this is the time wherein maximum input happens because of the adrenergic drive you're all in. Your brain will be very active, your brain will be very receptive, so don't waste even a minute now. Try to give your best and you will definitely succeed with flying colors. Yeah, on the list. Thank you.